yesterday.
Welcome to Gracefully Greying. I am your host, Attorney Henry Gornbein. Today on Gracefully Greying, we are going to be discussing a topic dealing with Parkinson's disease, which is also known as the snowflake disease, with my guest, Dr. Neepa Patel. Dr. Patel, welcome to Gracefully Greying.
Thank you for having me.
First of all, why don't you tell our viewers a little bit about your background and who you are?
So I am a movement disorder specialist. It's a subspecialty in neurology. And my background is I come from, I grew up around this area in Metro Detroit, and I went to University of Michigan for undergrad and Wayne State University for medical school. Did my neurology training in Boston, and then did a fellowship in movement disorders at Baylor College of Medicine in Houston, and then eventually came back here to practice medicine at Henry Ford Hospital.
Dr. Patel, what made you decide to go into neurology?
Well, that is an interesting question. I think when we're in medical school, we learn about everything, all parts of the body, and then we do rotations working with patients and physicians in different specialties. And from the beginning, neurology was just such an interesting and fascinating organ. It involves not only the brain, but the nervous system, the nerves, the spinal cord, muscles, and I just thought it was fascinating to learn about, and then I started taking care of patients with it on my neurology rotation, and it just drew me in like no other specialty.
And now you are a specialist in neurology and doing a lot with Parkinson's. Why don't you tell our viewers exactly what is Parkinson's disease? We hear about it a lot. It's also known as a snowflake disease, and tell us about it.
So Parkinson's is what we consider a neurodegenerative condition, and by neurodegenerative we mean that it's a slowly progressive condition that over time symptoms will accumulate and get worse with time. The hallmark of Parkinson's is based on a constellation of 4 features that we find on your neurological exam. One is slowness of your movements, stiffness of your muscles, incoordination, doing kind of fine finger tasks or fine foot tasks, things like cutting up food, buttoning up buttons. And then some patients, probably more than half of them, will have tremors, usually tremors at rest, but not every patient will have tremors. So it is a individual specific condition, even though it kind of falls under the bigger umbrella of Parkinson's disease just by the way of symptoms.
Is there a hereditary component to it?
So as I mentioned, and as you have mentioned, it's a snowflake disease. So there's more than one type and version of Parkinson's. So there is a small portion of patients who will have a really true family lineage where multiple family members, either parents, grandparents, aunts, uncles, and then perhaps siblings, will have Parkinson's disease, and it'll just run through the family tree. More often, it is a condition that happens rather sporadically, so there might be one person here, a distant relative elsewhere. And what we believe is that there may be some genes, not one, but maybe 5 or 6 genes that may put people at an increased risk of developing Parkinson's. And over the course of their life, 1, living long enough, so age is a risk factor for developing Parkinson's, but 2, other environmental factors and the interplay on genes may trigger Parkinson's to happen. So a little bit hereditary and a little bit not.
Is there any environmental component to it?
So we have done a lot of research and found kind of triggers for it. So there have been a few pesticides that have been identified in the past, and we're recognizing the role of various toxins. Pesticides are getting the most attention right now in farming communities and agriculture. Other factors, there was a flu pandemic in the early 1900s that triggered an outbreak of Parkinson's. So there are a variety of environmental factors, and we haven't put our finger on, that one specific factor, but rather maybe more than one thing that's contributing to it.
Dr. Patel, are we seeing more Parkinson's patients now, or is it a matter of better diagnosis?
I think it's a little bit of both. So one, compared to 50 years ago, the life expectancy has increased substantially. And so as people live longer, the the progression into Parkinson's disease occurs. I think also we've learned a lot about it, so we're diagnosing it much earlier and we have better treatments for it. So people are coming to our attention a little bit sooner as well.
Are there certain ages that is more prevalent as we age? I mean, what are typical ages of most of your patients?
Yeah, so we think of kind of three big spikes. Now, the largest population of patients will probably be in mid-60s to 70s that might start displaying symptoms of Parkinson's. Another big population that's at risk for developing it would be much later in age, so 80s. 80s, early 90s may have some really mild, subtle features of Parkinson's. And then a very small population, and these may be more related to genetic causes, of people who are in their 30s or 40s, early 50s maybe that develop it. Rarely do people younger than 30 years old develop Parkinson's, but there are some cases of that.
What are the stages of Parkinson's?
So the stages of Parkinson's is, I think, a loaded question. So they were the ones that we often refer to in the medical community are the Hone and Yahr stages of Parkinson's. And this was a scale developed before we had any treatment of it. So it doesn't follow true progression stages anymore because we have really good treatments that hold people at bay. And for simplicity's sake, stage 1, Hone and Yahr, means that one side of the body is affected and the other one is doing relatively well. Stage 2 is that both sides of the body are affected, whether it be stiffness, incoordination, or tremor. And then stage 3 is that we're starting to notice some balance impairment. Stage 4 would mean that balance is significantly impacted and you might need a walking aid, such as a cane or a walker. And then stage 5 is when somebody's primarily in a wheelchair and really limited by their mobility. Most people will live 20, 30 years in stage 3, 4. And sometimes we've taken people from stage 4, not treated with medications, down to stage 2 with medications. So it's more of a sliding scale these days. And I wouldn't hold people to the stage that they're diagnosed into.
When you're doing a diagnosis, tell us what you're looking for. If someone walks in and saying, I'm concerned, tell us how your initial contact would work for our viewers.
So the diagnosis of Parkinson's still to this day is based on a very thorough history and neurological exam. There's no specific test that diagnoses Parkinson's exactly. So in the history, I'm looking for a slow progressive onset, not something that just started suddenly one day and then kind of stays stable from there. That makes me think of other conditions, but something that kind of just is indolent and slowly creeps up over time. And then I'm looking for signs of, are you slowing down? Are you having a harder time keeping up with, say, walking compared to your spouse or your family member, someone in your age group? Are you having signs of incoordination, whether that be by changes in your handwriting or just fine finger tasks like using a cell phone or typing on a computer, buttoning up buttons? I hear a lot of symptoms of pain, stiffness, loss of range of motions. People can't raise their arms above their head or reach back to, grab a coat and things like that. Those are subtle signs of it, of slowness and incoordination. And then Parkinson's is also associated with a slew of other body areas affected that don't have a connection directly to movement. So a loss of sense of smell, changes in their sleep patterns and habits, constipation, urinary urgency and frequency are just a few that make me kind of think a little bit more of Parkinson's disease.
What about familial or essential tremor? Is that related to Parkinson's or is that a separate category?
So it is. It's a evolving definition, and I think as of now we recognize that there is some overlap between the two, where some people who have had 30, 40 years of just what looks like a classic essential tremor that later developed Parkinson's. We're not 100% sure if they're two completely separate conditions or if essential tremor in some people might be the very, very mildest, earliest signs of Parkinson's disease.
Now, Parkinson's is basically where the brain stops producing enough dopamine, am I correct?
Yeah, so it's a little bit more complicated than that, but
let's explain
dopamine is
that.
kind of the heart of the problem. And it's not that the brain stops it, but the brain cells in charge of producing dopamine, they start dying back. And that process of what triggers it to die back, we're not 100% sure what triggers it. But that's the combination of genes plus environment, we think. So as those brain cells are dying, the easiest way to think about it is your factory workers are being cut back. And so you're just making less dopamine. And so when you reach a critical threshold of not enough dopamine, then this starts affecting your movements.
Dr. Patel, can Parkinson's be mistaken for any other conditions?
Early on, when the symptoms are very subtle, I've had patients, complain of shoulder pain and reduced range of motion and be diagnosed with rotator cuff injuries, sometimes undergo surgeries and not necessarily have improvements with that surgery. More often than not, they're looking at all the different components of the disease separately. So somebody may see 3-4 specialists for constipation. They may see a specialist for sleep. They may see a specialist for their urinary problems. And the symptoms aren't so prominent or obvious, so they haven't kind of been able to put it in an overarching blanket. Some people are thought to have familial tremors initially, and then as more symptoms develop, that diagnosis gets changed to Parkinson's as well. And those are typically the most common. Rarely I'll have a patient be diagnosed with a stroke, though we're usually kind of in a stroke here. It happened all of a sudden, and then it's kind of stayed stable since.
Well, I know of a situation where someone had a stroke and then later developed Parkinson's. No correlation?
It depends on what part of the brain got injured. So the area of the brain that produces dopamine, most of it is the substantia nigra. So strokes in that area or the surrounding network of the basal ganglia can sometimes make a patient look like they have Parkinson's disease, but not really have the same translation long term.
What about multiple sclerosis?
So multiple sclerosis is a very different neurological condition. I would be hard-pressed to say that many of my Parkinson's patients have been misdiagnosed. The main reason is multiple sclerosis typically occurs in a much younger age group. We're usually diagnosing it for patients in their 20s or 30s. So less likely to affect people, though possible, as in the 40s, 50s, and beyond. Multiple sclerosis is a condition that also has a kind of injury, almost like a stroke-like injury that lasts for a few days and then starts recovering, and then may get another injury separated by time and space, and it's very discrete, neurological problems. And the last thing is an MRI of the brain, and the spinal cord will look very abnormal in a multiple sclerosis person as opposed to Parkinson's.
Can one lead to the other? And the reason I'm asking, I represent a client who's had multiple sclerosis for many years, and recently she told me she's now diagnosed with Parkinson's.
I would say in my career, and certainly I haven't been practicing forever, I have yet to actually see a true cause and effect.
Okay.
Now, many people who have multiple sclerosis and have had multiple injuries can appear to have the same symptoms as Parkinson's patients in terms of stiffness of their muscles, loss of dexterity, sometimes a tremor. But unless there's a very focal injury in in that basal ganglia circuit of the attributed to Parkinson's disease, I would still consider them separate.
Now, we already discussed the fact that pesticides, there are certain environmental things that may or may not have an impact. What about any medications?
So there are some medications that to our knowledge, we don't believe that it causes Parkinson's, so triggering that degenerative process, but it can make people appear to have Parkinson's. So the two biggest categories of these medications are the category is called a dopamine receptor blocker. And that can be anti-nausea pills or antipsychotic pills. So those used to treat psychiatric illnesses, many of which include depression, anxiety, and then schizophrenia and bipolar disorder. So when a person is taking that medication, they can display many of the same signs as a Parkinson's patient. However, when we remove the medication, those symptoms can resolve. They can make an early Parkinson's patient look much worse, and then we find out that there might be a little bit of underlying Parkinson's when that medication. So those are kind of the two things.
Now, I know there's a lot of research going on, and Michael J. Fox and his foundation has done a lot. Is there any way to reverse it?
So today, the only thing we have proven by science, lots of scientific evidence that supports it, would be to hold it at bay, and to slow its progression would be exercising. Apart from that, we are currently looking at multiple different compounds for the potential to slow down and or stop the condition. Reversing degenerative disease is really hard to do, because as those brain cells die, it's hard to make them grow back in the same way. But our goal, and we currently at Henry Ford, we have two studies actively ongoing right now, looking at a potential two different mechanisms of slowing down the progression. And we've completed a few studies as well, looking at strategies to slow down progression. So this is a hot area of research right now.
How many patients do you have currently who have Parkinson's? I'm just curious.
Goodness. Well, I'm a movement disorder specialist, so
Okay.
I may have more than the average neurologist. I think off the top of my head, a rough estimate would be at least 200 to 300 that I follow long term.
Let's talk about treatment.
Mm-hmm.
What are some of the ways you can treat Parkinson's? Let's start first of all with medications.
So medications are kind of the foundation of treating Parkinson's. Carbidopa-levodopa is probably the best medicine we have to treat Parkinson's, though there are several other medications that augment or work with that dopamine system to raise the total levels in the brain. So in addition to carbidopa-levodopa, there are a medication group called dopamine agonists, of which there's 3-4 different options in there. And then we have MAOB inhibitors, a few different options there to use as well. And then a few other extender medications and add-on medications that can help treat the symptoms.
Now, Receptor, isn't that one of them?
So that is carbidopa-levodopa
Okay.
in a different package. So it's a longer acting version of the generic medication.
So it's like a time release, is that the whole idea?
Yeah. And so, there's Receptor, there's also carbidopa-levodopa packaged with an extender pill called Stalevo, and then regular old Sinemet, carbidopa-levodopa in its immediate release form is available as well.
I've heard, and correct me if I'm wrong, that they're working on the idea, just like diabetes, people have an insulin pump. Is there something like that that's being done with Parkinson's?
Yes, there is. So commercially available, there is something called I just lost the word, Duopa.
Duopa?
The
Okay.
Duopa pump. It is a gastrointestinal tube, so we modify a PEG tube or a feeding tube, and we insert we being a surgeon will insert a longer tube into a special portion of the gut called the jejunum, and we give a infusion of levodopa. So same medication, levodopa, carbidopa-levodopa, but this is in a gel form that's delivered continuously.
Do you have any patients doing that?
We have a few patients doing that. There are other medications, other versions of levodopa in an infusion form as well under development. And one that we recently completed studies on is a kind of through the skin pump, though that's not commercially available as well. But we hope it will be in the near future.
What pain or discomfort is commonly associated with Parkinson's?
So that is, I think, a very personal symptom for each individual experiencing it. Many of the symptoms that I hear are probably related to muscle stiffness, cramping, and difficulty with just kind of range of motion. So it can vary from being in the shoulder, being in the hips or the legs or in the feet. Sometimes dystonia, which is an abnormal kind of posturing of a limb, can contribute to pain as well. And so those are the most common places that I hear of pain. But I've heard it all. So some people experience headaches as a part of their pain syndrome with it. Some people experience a lot of neck pain as well.
What about dystonia in the feet, where someone's feet or toes will lock up? Do you see that much?
That is a pretty typical dystonia symptom in Parkinson's. So I would say at least a quarter, if not more, of patients will experience toe curling.
And what is done to fight that?
Well, there's several different options. So in addition to optimizing your medication regimen, botulinum toxin, I think, works quite effectively for that. It's an uncomfortable procedure because I usually inject at the ball of the foot, but it helps relax the toes and provides a lot of comfort for my patients.
So basically the same Botox that people use for erasing the aging lines in their face or forehead can help fight dystonia.
Yeah, it was actually developed to fight dystonia and abnormal muscle movements, and then serendipitously people noticed that they had less wrinkles. So that's how it got translated into the cosmetic end of things. Yeah.
What about depression? Is that a sign of Parkinson's or a byproduct?
It is. So dopamine not only helps us move, but it gives us energy, motivation, and in some ways almost elevates our happiness. It's one of the happy chemicals, is what I like to say. So when your dopamine levels are down, there's a reduction in interest, energy, and may be associated with some depression. In addition to that, I think another more prominent part of depression is that dealing with chronic illness, not being able to function to your best ability all the time, and being, having variable symptom control throughout the day can also contribute to depression. So I think it has something to do with Parkinson's itself, and then also living with Parkinson's.
What about anxiety?
Anxiety is much more common in Parkinson's in general. It has a lot of people who are untreated or undertreated will feel a jitteriness or an anxiousness, an internal tremor, which can make them feel anxious. In addition to that, I think the same, variable predictability in the day and limitations in mobility and function at times can also contribute to anxiety.
What about falling? Is that a big issue as Parkinson's advances? Let's talk about that.
Absolutely. So as I mentioned early on,
Balance.
Balance is a component of Parkinson's and in part of the staging of Parkinson's. So balance is affected in a few different ways. The walking pattern that we all just take for granted, one foot in front of the other and being able to keep that forward motion without really thinking about it, that starts breaking down in Parkinson's. So some people will struggle with balance because their feet won't keep up with them. It's something that we call freezing of gait, where they'll be mid-stride and their feet just stick on the ground and it won't pick up. So their body keeps moving forward with their feet are stuck in one spot.
So I guess for a layperson, you could be walking along and your feet will just lock up on you and you topple over, is that?
Yeah, so they'll almost, what's described to me is get stuck on the ground and you can't pick it up. So if you can imagine, your whole body's moving forward, but if your legs stay stuck and your head's going forward, you'll lose your balance and topple over. In addition to that, other parts of walking imbalance is that a lot of patients will have trouble picking up their feet and clearing the steps so you can catch on cracks and obstacles on the floor, which can trip you up. And then the balance recovery, what we call postural instability, is also, or postural stability is lost. So if we were to, trip on something, most of us can take a big step
Right.
and recover, or stick our hands out really quickly and catch our balance. And Parkinson's patients move slow, so they can't recover as well. So instead of taking a big step to counterbalance or reaching out for something, they end up falling. So falling is a big problem in Parkinson's, and something that I spend a lot of time trying to prevent through physical therapy and other strategies.
What about, isn't there also a shuffling to the gait?
Yeah, so in the shuffling, it's sometimes the feet just don't pick up and they don't take big enough steps, so the top goes a lot faster than the bottom, causing you to kind of lose your balance because you're almost walking on diagonal. And the other part of shuffling is the tripping. You're just not picking up your feet large enough to clear the obstacles that are on the floor. Uneven sidewalks are probably the worst offender, where a lot of my patients have tripped, or they don't take a large enough step to climb a stair, and so they catch their foot on something.
You mentioned that sleep is affected. How is that affected?
So there's a few different components of sleep that are affected. Some patients notice that it's hard to fall asleep. They may notice their Parkinson's symptoms coming back, or cramping in their legs that might contribute to trouble falling asleep. Other patients of mine have trouble staying asleep. They can fall asleep easily, but 2-3 hours later they're wide awake, maybe experiencing symptoms of Parkinson's, or their mind's racing, or they can't seem to fall back asleep. And then there's another component of sleep called REM sleep behavior disorder. And this is where a patient is sleeping and they are acting out their dreams, punching, kicking, fighting, talking in their sleep. Sometimes they might roll out of bed, or they might wake up a bed partner who then wakes them up. So those are the most common causes of sleep.
Can there be nightmares as part of Parkinson's too?
Yes, so vivid dreaming is part of that scope, and then some people will say they're having nightmares because they're acting out their dreams. So dreams may be remembered more clearly, and they may be a little bit more threatening and scary than
So there could be,
typical.
someone could be sound asleep and all of a sudden start screaming.
Mm-hmm. Yeah, and so that's REM sleep behavior disorder, and very often one of the early signs of Parkinson's. So I look for that when I'm diagnosing Parkinson's.
We're down to about 30 seconds. Are there any final thoughts you want to share with us before we wrap up the first portion of our show on Parkinson's?
Well, there's so many things. I would say one of the most important things anybody with Parkinson's, or as they're aging, that they can do for themselves is exercise. It's one of the only things proven to really slow your progression to disability, because the better you use your body today, the higher you raise the bar for where you're falling from. And it just reinforces these mechanisms that are slowly breaking down in degenerative conditions.
Okay, we're going to take a short break.
Okay.
We're going to be right back with Dr. Neepa Patel as we discuss issues involving Parkinson's and some of the more advanced treatments as we continue our dialogue.